to give them home health care.
Right.
That's true. But in the aggregate, so many people are at home roughing it. As soon as you give this program, so many people will come running out to take advantage of it that have been roughing it at home, that it would have been cheaper for the system to just wait until they give up and then suck it up and pay the nursing home costs. The line item on that budget would be lower that way than giving them more decent care, giving everybody home health care. So some of these costs are going to be hard to control. But we've got to figure out how to do cost control next, and once we've got access, and we've got to work with the National Medical Association, because they're the only ones really working with us on this. The American Medical Association is an adversary position. We've got to figure out how to have more health clinics, more access, stop paying fee-for-service and do some more global or some other kind of reimbursement to encourage good care, not more care. And that's going to be hard to do. So we need to work with the National Medical Association to make sure we get it right. So with that, Donna, thank you for the opportunity to be here.
Thank you. Let's give our panel a round of applause. And we have about 15 minutes for questions and comments. And as you come up to the mic, I want to mention a couple of things. I'm just going to use my third slide, the third one. But a couple of things that were not really covered: investment in historically black colleges and universities and minority serving institutions. $85 million to historically black colleges and universities, $15 million to predominantly black institutions. This is for training the healthcare workforce. As we expand, this is our opportunity to diversify. Community transformation grants, which would provide grants to states and local government agencies as well as community-based organizations for the implementation, evaluation, and dissemination of evidence-based community preventive health activities. Grants that your communities can take advantage of, and grants for community health workers is also a part of this. And this is for community-based organizations to train the community health workers, people from within those communities to reach out to people living in the neighborhoods and connect them to care and services and to provide the kind of support that they might need when they do have a chronic illness.
The diversity of the healthcare workforce, and I'm wondering if there's anything in the legislation, and anyone who can answer, to address that issue, the recruitment and retention. I know that there are programs through HRSA that we get funding for, and we know also that there's a shortage, and now we're going to have to address all of these new patients. How do we fill that gap in terms of the diversity of the healthcare workforce, and then the cultural competency of those who are going to have to encounter all of these new patients, and they don't tend not to address those patients, they tend not to work in rural areas, etc. I have other questions, but I'll talk to y'all afterwards. Thank you.
Okay. And does anyone want to address that? But there are provisions dealing with cultural competency. I talked about the funding for the minority serving institutions to train health professionals, expansion of National Health Service Corps and loan forgiveness programs, grants to train public health workforce, nursing workforce, nurse faculty, and all of those provisions have specific reference to increasing the diversity and the representation of underrepresented minorities in the healthcare workforce.
Can I make one other point on that? You mentioned all these new patients. People are not going to get any more or less sick as a result of this, and people who get sick are going to, even whether they have insurance, are going to end up in the healthcare system. Usually it's the most inefficient way. So the idea that there will be new patients, there may be more patients for primary care, but whether or not the system has more patients is, I think, is an open question.
Hi. Good morning. I'm Sherry Davis, the State Director here in Mississippi. Dr. Jones, I have a question for you. You mentioned on a slide, how do we address the challenges of the health insurance exchange, which will base coverage largely on service provided to Medicaid recipients? Could you expand on that, please?
Certainly. As I understand reading the bill, and I invite you, if you've got a bored weekend, spend the weekend reading the bill. There are provisions that describe that for the health insurance exchange, that there will be regional activities, and they will be based upon what the states in that region agree will be that minimal benefit package that will be covered, and it'll be largely based upon the Medicaid programs that they've agreed upon. And one of the problems, as I've read about it, is that Medicaid being a state-federal partnership, there are states have a range, a certain number of things they must cover, and a range they can choose. So the fear I have is that that may be a point of barrier, or a point of impasse for us, that states may not agree on what that common benefit package should be. And I think that could be a problem for us in getting the kind of coverage we need with the health insurance exchange.
I will interject. One of the provisions that we fought for relating to that issue is to make sure there is a federal minimum standard. If you looked at some of the health care debate between Democrats and Republicans, that was a key issue, whether or not there should be a federal minimum standard, and we were successful in getting that in there.
Just to correct my slide, that should be the 10th to the 13th, sorry. Last question.
Good morning. My name is Dr. Corshell Nash. I'm a primary care physician, health policy person, and medical director in the Arkansas Minority Health Commission. And Congresswoman Christensen, your first statement when we opened this session was critically important for all of us in the room, I think, and that is that this battle continues. The legislation is there, and I'm very happy to have been a part of that process in my state. But my struggle now is about the oversight, which is a direct segue from your point. If we don't get the good things right, we're not going to have the intended consequence. So my question to you is, how do we work in states and work collaboratively with you to make sure that we get the things that we're supposed to through the Health Equity Leadership Council?
That's a good question. And we will tackle that on Monday morning, because but we will when we meet, because one of the ways that we're going to do this, and several times a year, and the first one upcoming will be in September when we meet with mayors. The CBC meets with mayors and state legislators, black state legislators, and we will be communicating with them on a regular basis, as we go through the process. But it's critically important that we get the information out to communities. There will be some. We're hoping that we'll be able to do some large conference kind of calls. Our foundation has a Black Health Empowerment program that goes to different communities, and that'll be a part of their program. But it's what we want to make sure is that our communities know what's happening and benefits optimally from the bill. So we will be tackling that on Monday. Thanks.
Yeah.
Yes.
Just a quick statement. I think that's an excellent point. I think what we really have to do is to make sure that we incorporate our communities, that we have participation from our communities. We also need to make sure we have our organizations, whether it's our business, whether we're talking about health care, but all of us working together can certainly make things much better in terms of being able to get what we want and need. So unless we do that and we have disconnects, things are not going to happen the way it's supposed to be. So fortunately, this is still dynamic, still moving, and we just have to make sure we do all that we can, working together in harmony to get the things that we need to get.
And there's one issue that I've taken a particular interest in working with the Children's Defense Fund, is what the minimum standards are going to be for children. And we kind of backed into, I think, a good situation, because the package of benefits provided by Medicaid are actually much stronger than what most private insurance companies do. They have a thing called EPSDT, which is early periodic screening diagnostic, and I'm not sure whether the T is treatment or testing. Treatment, which is a comprehensive package. They get just about everything they need. We wanted that as the minimum standard. We wanted that Medicaid package as the minimum national standard. We weren't able to get it, but the national standards haven't been developed yet. Hopefully they will develop as close to EPSDT as possible. And second, you say we're fighting to make sure the thing works. Actually, the fight is making sure the thing stays.
Oh yeah, that's true.
I mean, you got people running all over the country talking about repealing, what we did. And if the wrong side takes over, even if they're not able to outright repeal, they will able